Rather very short presentation on target emmetropia, ocular surface stabilization and achieving refractive surface for a new presbyopia correcting intraocular lens. Good morning, everybody. And as you know, I'm the panelist and the last speaker for the session. So, of course, no financial interest has been accepted for publication in an esteemed journal. So, nowadays, younger patients are having cataract and becoming more demanding regarding, spectacle-free independence and visual satisfaction. And we have to cater to such patients by our careful selection. So refractive success is limited by factors that limit actually the accurate IOL power calculation, the tendency for photic symptoms, or the cost. And these factors summarized as red flags, and we present an approach to a patient who, despite several red flags, achieved refractive success. So this was a 53-year-old female with complaints of frequent change of glasses and diminution of vision, who was wearing plus-part spectacles all her life and bifocal glasses for the past decade. She had been using heavy eye makeup since her teenage with occasional contact lenses, a fashion designer by profession. The ocular examination showed a UCV of 660, 636, which was corrected to 66 with a plus 2.25 and an N6 by an R of plus 2. The other positive findings were heavy deposits of coal and glitter on the agnetha with meibomian gland disease grade 2. And there was also moderate dry eye disease with a decreased T by to 5 to 10 seconds. And the pupillary size was 4.75 and 5 respectively. The pentacom chord mu was 0.6 and 0.4 in all others types of chords. All other findings were normal. So she was advised sequential 2.2 phacoemulsification, but she demanded complete spectacle independence, and her occupation wanted fine tailoring work to be possible, and she was also so demanding and looked like a type A personality. So we tried to defer her, implantations till we gave her spectacles for the time being and treated her meibomyitis and dry eye with warm compressors, lid massage, cleaning, tablets, doxycycline, drops of sodium hyaluronate, cyclosporin and azithromycin, and told her to avoid eye cosmetics. However, she had poor compliance and needed 6 months for treatment, during which her pentacam values and IOL master 700 values changed, and she was monitored on the basis of ocular surface debris, consistency and expressibility of meibum, and patient-reported compliance to therapy. During this, her cornea profile became regularized, her aberration values improved, the curvature regularized, the corneal part symmetrized, and the sphericity became more favorable. And then the comprehensive visual needs assessment questionnaire by J&J was used to determine the proportion of her tasks and preference for near and intermediate vision. So based on this, a hybrid EDOF plus trifocal IOL design was preferred, and because the patient's affordability limited the choices to Indian lenses, so using a Barrett's Universal 2 formula with a plus 22 diopter lens, uncomplicated phacoemulsification was sequentially done in her 2 eyes. And at the end of the first POD, she had a 6X and 6 vision, and a visual function questionnaire 3 out of 7 showed no symptoms and no acceptance. So last follow-up, she had no symptoms, the lenses were well centered, without PCO. Then she had reduced her indiscriminate use of eye cosmetics and was very happy about the spectacle independence, and had to be maintained, of course, on sodium hyaluronate eye drops all her life. But the learning points are that bilateral, this multifocal IOLs are better, and as of that, and EDOF lenses have got better contrast sensitivity, a decreased spectacle dependence for all distances, and lesser visual disturbances compared to bifocals. And then, therefore, literature really lacks this reviews of our AdTech Extend IOL, the Indian multifocal plus EDOF. So in a patient who was first unsuitable, we implanted this, and of course the IOL master and Shimflug helped us in this case. But then after ocular surface optimization and MGD treatment, we were able to achieve this refractive surface. This is one of the few case reports using the J&J Vision questionnaire for visual needs assessment, as well well as the VFQ 3 out of 7 questionnaire for patient-reported outcome measures. Of course, we have limitations of not being able to measure the contrast sensitivity, the wavefront aberrometry, or the post-operative photic phenomena in varying light conditions and stimuli. However, she has reported no symptoms. The conclusion is that assessment of needs and stabilization of the ocular surface, meticulous corneal assessment, and IOL power calculation are mandatory for refractive surface. And properly performed, the advantage of spectacle independence can be offered to all the patients who are otherwise deemed unsuitable for presbyopia correcting IOLs. Thank you for your kind attention. These are my references. Yes, right. But yes, in the type A and with MGD and with, yes. I think I had a very good person to actually calculate the part, and we actually waited for the ocular surface to stabilize. And then when we were fully confident that, okay, now her power calculation is coming as consistent, and then we dared to implant this lens. Actually, we dared to, and we got away with it.
Adding the EDOF to trifocal, does it add to something else? Because already you're giving trifocal, adding EDOF, does it offer any advantage to the patient?
I think because this was primarily because, I think AdTech Extend has got this claim, and rightly so, of being able to avoid the photic phenomena as far as things are concerned. And one other thing which prompted me to implant this lens was that she was not a person who used to drive at night. So we said that, okay, let us go with it.
Nice presentation. Thank you.